afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on immigration and migration as a social determinant of health and use of ICES data. My name is Sarah Bucket, and I am a scientist at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin with today's presentation, I would like to acknowledge and respect the lands, skies, and waters of Ontario, including for their contribution and sharing to support of all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I acknowledge and respect traditional territories and communities of the Métis Nation of Ontario. I acknowledge and respect Inuit connection and contribution across these lands and waters. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys, worldviews, and indigeneity. May we respect and honor the many connections, relationships, and life journeys of Indigenous peoples and their indigeneity to the lands, sky, and waters across all Ontario since time immemorial to this very day. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. Lastly, I would like to acknowledge Daniel Coles, who is the author of this land acknowledgement, and thank him for sharing it with us. I will now mention a few housekeeping items. So just so that everyone knows, the chat pod has been disabled to limit any distractions during the presentation, but please use the question and answer pod if you do have questions during the session. A discussion and question period will follow the presentation, and if at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of the session, I have no conflicts of interest. It is now my great pleasure to introduce the speaker for today's presentation, Dr. Suthisa Wanagaratne. Dr. Wanagaratne is a senior research associate at the Leong Center for Healthy Children at the Sick Kids Research Institute and a fellow at ICES. She is a social epidemiologist whose work considers immigration to be a social and structural determinant of health. She is interested in harnessing the power of administrative health and social data to contribute to and facilitate positive social change, which improves the health and well-being of minoritized communities. She holds a PhD and an MHSC in epidemiology from the Dalla Lana School of Public Health at the University of Toronto. And now I will pass it over to her for her presentation. Thank you.
Thank you, Sarah, for the introduction, and thank you all for attending the presentation today. I'm really excited to be able to talk about this work with you. It's definitely something that I've worked on for a really long time, and I'm super passionate about it. So yeah, really appreciate the opportunity to talk about this. So I wanted to start off by saying that I have no conflicts of interest. Oops, there we go. So in the advertisement for this session, you likely would have read the learning objectives, but I will state them here to start off. So the first objective would be to appreciate that immigration and migration is a structural and social determinant of health. Second, to understand the strengths and limitations of the Immigration and Refugee Citizenship Canada database, housed at ICES, which I refer to as the IRCC database. Should be able to describe the uptake of COVID-19 vaccines among immigrants and refugees in Ontario, and importantly, also be able to describe the facilitators, barriers, and determinants of vaccine uptake among migrant populations. I also have a little bit more of a detailed outline of the things I'll talk about to flesh out those objectives a bit more. So I'll be talking about Canadian immigration policies and how they relate to immigrant selection. I'll also be talking about the current immigration system as well as some trends. The main focus of the talk, I'll describe how immigration is a social determinant of health. I'll help visualize that with Statistics Canada data in terms of immigrants and refugees that live in Canada, specifically Ontario. And then I'll go on to talk about the IRCC database at ICES, the data elements as well as its data quality. Another aspect of the use of these data is that we've been developing guidance around anti-racist use of race, ethnicity, and immigration data ICS, and I'll touch upon that as well. I'll also describe how we use these data to examine COVID-19 vaccine uptake among immigrants and refugees in Ontario, talk about those barriers, the facilitators and determinants, and then I'll also touch upon the importance of community engagement and vaccine uptake strategies. So to start off, I wanted to talk a little bit about the history of immigration to Canada. many years ago, before I became interested in immigrant health research, I visited the Canadian Museum of Immigration at Pier 21 in Halifax. I'm not sure if many of you have gone, but I highly recommend it. Super interesting. And the website is also really great. So a lot of the information is from that website. And a few years ago, I was just taking a look at the website and I came across this quote, which I'll read, which is on the slide as well. So immigration legislation is ultimately a reflection of society's beliefs and attitudes, revealing Canada's history of inclusion and exclusion. And it's really struck me as I don't think Canadians often think of their system in terms of exclusion. We think it's a very inclusive system. But there's several examples, that I'll highlight here that really where the purpose was inclusion. So the first I'll mention is the Chinese Immigration Act of 1885, which, as you could guess, excluded Chinese immigrants. The Continuous Journey Regulation Act of 1908 excluded immigrants from the Indian subcontinent. And the Order in Council PC 1911 excluded Black immigrants. So in 1966, this was recognized. It was recognized that many immigration policies were in fact discriminatory, and that immigration officials actually had too much discretion in how they chose immigrants. So they wanted to overhaul the process, and in addition to trying to rectify some of those things, they also acknowledged the country needed to fill demands in many occupational sectors, so manufacturing, managerial, professional, and technical occupations, that led to a restructuring of immigration in 1967. So again, in 1967, they were aiming for a more objective admissions process. So they shifted to what they refer to as a point system, and it was a score in 9 categories. Some of them I have listed on the slide. So these are education, training, personal character, occupational demand, age, French, English, knowledge, and there's a few others as well. Essentially, this system is the predecessor of the system that we see in place today, particularly for economic immigrants. That point system still is something used to evaluate and include economic immigrants into Canada. There are other inclusion/exclusion criteria for the other categories of immigration, which I will talk about in a few slides as well. But ultimately, the system was shifted to be, less discriminatory, but it still has elements of inclusion and exclusion included. So my point of all this is really that immigration to Canada is really a highly structured system. It's very selective, and the primary purpose is really to fill economic needs and enhance prosperity of the country. So this slide here is just to visualize the changes that occurred, particularly with that shift in 1967. You can see that up until that point of time, there was mostly immigrants from Europe that were in Canada. And then 1967 onwards, you can see that most prominently in the 1971 column. It shifted away from European migration. And you can see, in 2011, the majority are not from those countries anymore. And this stands today as well. So to move on to what the system looks like today, there's kind of 2 main streams, and the first one that I'll be talking about is permanent residency. And so there's several different application criteria for different streams. So the one that I've spoken about already is the economic immigrant stream, and again, that's they're selected based on that point system, a different deviation of it, but still a point system. And every year, around 60% of all immigrants come through that stream. There's also a family class, and they are sponsored by Canadian family members, and around 30% each year are family class. There's also refugees, and all refugees meet the UNHCR definition of a refugee, and every year around 10% of all immigrants to permanent residents to Canada are refugees. There's some subcategories of refugees, which you'll see in later slides that are kind of demonstrating that are in the graph. So I'll talk about those briefly as well. So government-assisted refugees here, referred to as GARs. There's also blended visa office-referred refugees, which is the newer program. They're selected by the UN based on vulnerability criteria. And one of these criteria is actually a medical need. So that's how that group is selected. Privately sponsored refugees, or PSRs, are often family members of Canadians already, and they're sponsored by private citizen group. So all of these groups that I just spoke about are referred to as resettled refugees, and they're either sponsored by the government or they're sponsored by a private citizen group. There's also refugee claimants or asylum seekers, and they have to go through a hearing process before they become permanent residents, and they are unsponsored. Nobody, the government nor a private citizen group sponsors them, so they're here entirely on their own. An important aspect also is that permanent residents can apply for Canadian citizenship if they meet specific criteria. So another important aspect of the immigration program, immigration process, is that all immigrants to Canada have to undergo an immigration medical exam. And one of the reasons, one of the ways that this immigration medical exams is used is actually to assess inadmissibility, and it is can be based on 3 criteria. So through the IME, the IRCC assesses whether someone's a danger to public health, a danger to public safety, or if their health and social service use is projected to exceed a specific threshold. There's a monetary threshold that's changed over the years, but if people exceed that threshold, they can be refused admission. So economic immigrants and some family class immigrants are actually rejected if they exceed this threshold. And refugees and, again, some family cannot be rejected based on this exceeding this threshold, and that changed as of 2002. So in terms of healthcare coverage for permanent residents, economic and family class immigrants are eligible for OHIP 3 months after they arrive in the country. Resettled refugees, those 3 groups that I spoke about, are eligible for OHIP at arrival, and they also have additional healthcare benefit coverage through Blue Cross, and that's just for the first year after they arrive. Refugee claimants only become OHIP eligible after they have a successful hearing, and at that point they are eligible for permanent residency, and they are referred to as protected persons. Importantly, while they're waiting for their refugee hearing, which in some cases can last many years, they're eligible for the interim federal health program. So it's a federally funded healthcare program. And through the ICES data, we cannot track the use of that data because ICES data has OHIP claims only. It's pretty widely known, more anecdotally than from like a really heavily researched perspective, but we know that there are numerous barriers to accessing IFHP funded services in Canada, and there's a really great article by Chen et al. I have up on the screen there that's published in Refuge if you're interested in learning more about that. So moving on to the other like major category of immigrants to Canada. So I talked about permanent residents. There's also a temporary resident stream. This includes temporary foreign workers, people in the International Mobility Program, as well as international students and refugee claimants. They can be eligible for OHIP only if they have a valid work permit and they have worked full-time for at least 6 months in the year. Importantly, they cannot apply directly for Canadian citizenship. They must become permanent residents first. And another important thing is that most immigrants in the or migrants in the temporary foreign worker stream have very few pathways to permanent residency. And the one exception that I know of is the caregiver stream. So there are people, mainly women from the Philippines at this point in time, who come to Canada on a temporary worker permit. And they either take care of children or they take care of people with high medical needs. And over time, they have developed a pathway for permanent residency for this group only. And, in recent years, there's been a lot of discussion around undocumented migrants as well. And in Canada, there's some research that suggests that actually many undocumented folks were actually temporary residents or permanent residents, and their permit has since lapsed. So just to say that, undocumented migrants in Canada haven't always have been without legal status. They've been likely been legal in the country at some point in time. An example of the temporary residents that you might have heard of during the pandemic, particularly in the first year, there was a lot of discussion around really high exposure of migrant agricultural workers in Ontario, a lot of deaths, but also many infections. Here, this article cites, it indicates that agricultural migrant workers were had the second highest number of infections of workers that were captured in the data. So only second to healthcare professionals. So in terms of recent trends, for permanent residents, for many years, it was only around, not only, but still a substantial number, around 250,000 permanent residents were admitted each year. Around 2015, that started to creep up to around 300,000. And in the coming years, the IRCC projects to accept around almost 1 million, almost 500,000, permanent residents each year to Canada. In terms of temporary residents, I was able to pull some numbers and put together the graph there on the slide. The blue line on the top indicates the total over time, and you can see it's slowly increasing. In 2015, it was around 700,000, mostly driven by international students and folks in the International Mobility Program. And in 2021, I was able to find a stat that there was around 900,000 folks with temporary resident permits in the country. So a lot more temporary residents than permanent residents recently. So now I'll move on to talking about the social determinants of health. And hopefully many of you are familiar with this framework that was developed by the World Health Organization. I won't spend too much time on it, only just to kind of anchor our understanding of what we're talking about when we're talking about the social determinants. So we have the socioeconomic political context on the left, influencing this socioeconomic position, further influencing intermediary determinants such as material circumstances, which all go on to impact health and well-being. In terms of immigration, I would think it kind of fits in under public policies. So this is just kind of like to give us an overview of all the social determinants and how immigration fits into our understanding of what those are. So I also, when I first started working in this field, there wasn't a ton of discussion about thinking about immigration as a social determinant of health. I came across one paper that was published in 2006. That's there up on there on the left-hand side by the International Organization for Migration. A really great global perspective if you're interested in that read. Recently, in 2015, there was a really critical a review in Annual Reviews of Public Health by Castaneda et al., which is mostly an American perspective, but I think it's really quite relevant for other high-income countries and Canada as well. So the main points of their review, I'll kind of go over here. So the first one is most immigrant health research really has a narrow focus on behavioral and cultural topics. And when the review looking through the behavioral lens, they found that most of the literature, was suggesting that because it was behavioral, individuals are responsible for their poor health. And with the cultural lens, it was really that the culture or the race ethnicity of the individual was somehow to blame for poor health. And the author's main point, and one that I really strongly agree with, is that we must shift our focus to thinking about immigrant health through a structural lens. So beyond access to healthcare, we must also look at access to housing, food security, living and working conditions. And I think, the experiences through the pandemic in Canada really make that point quite aggressively. So I also wanted to move on, I'll just move on to the next slide here and talk about another framework that I think is important when thinking about immigrant health. So the social determinants of health, kind of broad overview, and this one specifically thinking about immigrant health. This is published in Social Science in 2012. It's by Acevedo Garcia and colleagues. And it makes some important points. The framework emphasizes that the health of immigrants, as well as their families and communities, are really embedded in both ascending and receiving societies. So I've kind of highlighted both of those in blue on either side of the slide here. And the other point that the framework makes is that there's really a need to address the social determinants of health, both in the sending country and the receiving country. So you'll see that the social determinants of health are indicated in both of these boxes. And it's important to think about that cross-nationally, as well as across the life course, integrating both the sending and receiving context, the migration process, as well as transnational ties, which essentially means how frequently an individual might continue to interact with their country of origin. So really helpful in thinking about many complex factors that influence immigrant health. And some of these will come up when I talk about vaccine uptake and those barriers and facilitators. And I just wanted to briefly touch on, some of the things we talked about already. We talked about immigrant selection and immigrant categories and how that is related to the social determinants of health, related to the sending country. We talked about health at migration, referred in reference to the immigration medical exam, so how that can shape health before arrival. In immigrant health research, we often talk about duration of residence and length of stay. That's really can think about that as a proxy of the process of migrant adaptation. And I also just wanted to again highlight this idea of transnational ties, that an immigrant is their lives really unfold across borders. And that again, that point will come up later in the slide as well, or later in the presentation as well. So finally, I circle social determinants of health in the receiving country as I go on to talk about, what those social determinants of health look like in statistics, using Statistics Canada data, looking at immigrants. So I was able to pull some data from the 2021 census. And up on the slide here, you'll see immigrants on the left side, non-immigrants on the right side, and looking at what Statistics Canada refers to as a visible minority status, and I'll refer to as race ethnicity. So you can see that for immigrants, around 70% of immigrants are would be considered racialized, and then only around 12%, 11% of non-immigrants are racialized. So important difference in experiences of racism between the two groups. I also have a number of slides using the 2016 census data that kind of look similar. So I'll walk you through what they look like, and you can kind of apply the same logic as I go through the others. So on the left side will be females, on the right side will be males, which I'll reveal in a second. Each column is one of those immigration categories that I have referred to previously. So we have refugees, caregivers, that have come through the economic stream, formerly temporary residents. We also have family class, other economic class immigrants, and all compared to non-immigrants. So again, this graph is looking at language most often at work, used most often at work. And the colors that the non-gray is essentially folks that speak either English or French, and the majority speaking English. So very high competency in those languages for both males and females. But you'll see that, refugees, family class immigrants, and even some other economic class immigrants also speak a non-official language at work. So, in conjunction with, their use of non-official languages as well as their racialization status, I just wanted to briefly touch upon how, some of these factors might manifest in discrimination in healthcare services for immigrants in Ontario. So there's not too much research out there. I was able to find this one paper that was funded by the CIC that was a part of the Welcoming Communities Initiative. And they also reiterate that there's very little research exploring how discrimination influences newcomers' relationships with healthcare providers in the healthcare system. They did a literature review that found most discrimination is quite subtle. People find it really hard to identify, but they did point out some things that they felt were discriminatory. They did some key informant interviews with healthcare providers as well as immigrants and refugees across Canada. They identified some points of interpersonal discrimination. So this manifested in denial of service based on various factors such as language ability as well as insurance type. People experience discrimination based on accent and language and race, ethnicity. And important to highlight that, this really influenced how people access healthcare services. So this leads to some people deciding not to access healthcare services at all, changing healthcare providers, seeking healthcare medication, healthcare and medication from other countries, or seeking alternative forms of healthcare. They also identified some aspects of systemic discrimination in the healthcare system as well. So now moving on to what education looks like. Again, this a similar format, and that with the darker blue describing higher levels of education. So what I wanted to point out here was that even caregivers and all economic immigrants have much higher proportions of people that have finished university or higher compared to non-immigrants. This is true for both males and females. So interesting differences for education. Also, some refugees and some family class immigrants generally have lower levels of education compared to non-immigrants. And this, I apologize for the busyness of the slide, but really what this slide depicts is a difference in average income between immigrants and non-immigrants across all of the national occupation classification categories. So each grouping of the bars there is a different occupational classification, and blue is females, orange is males, and all of those bars drop below zero because across all occupational groups, both males and females earn less. People learn less if you're an immigrant compared to whether you're a non-immigrant. So really important differences in income across all occupations. So you can imagine, some reasons why this might be. And, I was able to find these two papers that described there's substantial employer discrimination. So this first paper published in 2011 basically identifies that there's substantial discrimination across a variety of occupations towards applicants that had foreign experience. For those that had Indian, Pakistani, Chinese, and Greek-sounding names compared to English names. So this is a barrier to even getting a job interview. And they also found in the next study that companies that had a larger number of employees discriminated less than those that had smaller numbers of employees. So just two studies to kind of emphasize that discrimination is possible in the workplace and it's happening and can influence income taken home by immigrants in the country. So I was able to also do some analyses trying to understand a little bit more about COVID risk. So I mapped the occupational classification to the Vancouver School of Economics COVID risk assessment. You can look up the methodology on that. So I mean, not a lot of differences. You can see that females on the right side definitely have greater exposure than males. And one point that I wanted to point out was that economic caregivers who are female have greater exposure than females in all the other categories. Also, another factor that we talked a lot about in terms of COVID exposure in the pandemic was household exposure. And here you can see the green bar indicating multi-generational households. All those immigrant categories have greater proportions of folks living in multi-generational housing, but then also even greater proportions of people living in other census family households, which is essentially people that aren't family members living in the same house, so two or more people. So important differences in what households look like. So now moving on to talking about the IRCC database at ICES. So it includes permanent residents who intended to land in Ontario between 1985 and 2017. An important aspect of that data is that it doesn't identify people who arrived in Ontario after 1985, and then before 1985, and it also doesn't identify immigrants who would have landed in another part of Canada and then moved to Ontario. So those folks aren't included in this database. We can't identify them. And so they would be included in the Canadian-born long-term resident group, which you'll often see in ICES studies. In my slides, they're referred to as the other Ontario residents. In terms of how the data elements are collected, they're collected for that immigration application process that I've talked about already. They're mostly collected or entered by the IRCC, but some are also entered by Canadian Border Services Agency. Most of the data elements are verified for economic principle applicants, so things like language ability, education, because those influence the point score. Those are verified by the IRCC, but for other applicants, they're self-reported by the principal applicant. So in terms of data elements and data quality, I'll just go through them quickly here. We have immigration category, which is, I've talked about those already. There's really fine categories, but all of them will roll up to the major categories that I spoke about. For all of these variables, I've also indicated the data quality. So most of these have missing with less than 1%, so or not missing at all, but there's one at the very end, which I'll talk about that shouldn't be used. So in addition to immigration category, there's family status. So in addition to principal applicant, other people come through as non-principal applicants, so that's indicated, whether they're family, whether they're children. Well, there's also educational qualification at arrival, as well as years of schooling, and those have they're good quality variables as well. But one thing to note is that obviously with time this will misclassify, particularly for children, but then also many immigrants will undergo retraining of some kind in additional education. So with time, those will become less valid. We also have official language ability to arrival, so French or English knowledge, and again, that will misclassify with time. There's also mother tongue, literally hundreds of languages listed with this variable. We also have country of birth or country of citizenship, and these all can be rolled up to regional classifications. I also just want to make a note here that these countries, their groupings don't necessarily translate to what we think about as race ethnicity categories. And I also just want to kind of put it in people's minds to think about country of birth and country of citizenship as man-made. Borders are man-made, they're socially constructed. So if you're going to use country of birth, what does that mean to you in your studies? Just something to think about. We also have year of permanent residency. So in addition to service use dates in ICES data, that's how we would estimate duration of residence. And we also have national occupational classification. So those not categories, but there's super high missing and not meaningful values. So not a variable you can use, unfortunately. So there's also a paper published in 2016 by Maria Chu that describes the quality of this linkage, the IRCC database to the registered persons database. So in general, very high linkage, around 86%, and there's few systematic differences between linked and unlinked individuals. If you want to know more about it, you can go and read that study. And what I'm super excited about is there's new IRCC data being integrated at ICES currently. So it's a national file. So we'll be able to identify those immigrants that came from other provinces to Ontario, over time. We'll be able to identify temporary residents who eventually transition to permanent residency. We were able to identify temporary residents who don't transition to permanent residency. So an important group that we know very little about in terms of their healthcare use. It also will include arrivals up to 2020, and we have an application identifier as well. So we're able to see all the people who came on the same application, likely family members or extended family. So interesting variable to think about analytically as well. So I also, for people interested in using the IRCC data, I also want to highlight that over the last couple of years, we've been developing guidance around guidance for anti-racist approaches to using race, ethnicity, and immigration data at ICES. This really comes from a place of trying to minimize the harm that can come from publishing on these categories and kind of not being able to contextualize it properly. But we also recognize the tremendous power of using these data and using them well. And we really want people to use these data to illustrate the impact of racism on health, advance health equity, or evaluate solutions to improve health. So the goals of the document are to guide appropriate use of these data, promote community-driven research, sustain anti-racist research with meaningful community engagement, develop community data governance, as well as ensure accountability and transparency. So this document is being finalized, and it's undergoing internal review right now. So hopefully it'll be released in the near future. So finally, moving on to use of the IRCC database as an example. We were able to link that data to the COVAX data and look at vaccine uptake. And these results are quite old at this point in time. These are looking at uptake only up until August of 2021. But we were able to do this analysis for Ontario as a report, and we also did them for a few public health units in the province who have a high number of immigrants and refugees. So it would help them kind of in the decision-making process. So the team of us, worked on this, and I'll show you some of the results in graphical format. So here we're looking at immigration category, some of those categories that I talked about already. So all of these on the left-hand side of refugees, family, economic immigrants, as well as those other Ontario residents. So you can see in the red square that I've highlighted here, economic caregivers have really quite high, or had quite high uptake, around 80%, and this was even greater than other Ontario residents. And just to give you a little bit more context around this group, again, I had said previously that they came to Canada often as caring for people with high medical needs or children. Many of these people continue to work in healthcare as personal support workers or other positions in healthcare. So kind of explains their high uptake. They would have been eligible, one of the first groups to be eligible for vaccines, and had great uptake. So yeah, greater than other Ontario residents for that group. Importantly, we see lower uptake among some groups of resettled refugees. So between 40 and 56% that had 2 doses. So here we're looking at refugees on the left and non-refugee immigrants on the right, and this is stratified by the recency of immigration. So not huge differences, but we did notice that for refugees that were most recently in Canada, so those were in Canada for less than 10 years, only 50% of them were double vaccinated at this time. And on this slide here, what we're looking at is quite fine regions of birth. So all those countries of birth were rolled up into regions. And the reason why we did this was because we thought that this, was very loose proxy for culture, for language, for groups that, could use these data that were relevant to their community. So this is why we looked at them in this way. So I'll just point out, a few groups of immigrants from, Southern Africa, from East Asia, Southeast Asia, South Asia had very high uptake, between 80 and 75% were double vaccinated at the time of this analysis. But then also those from Central Africa, the Caribbean, and Eastern Europe also had very low uptake of 2 doses at this time. And, we've since done some additional analyses, and these patterns, although obviously uptake has improved, the patterns are still quite same in terms of the disparity across regions of birth. So quite interesting. I think one of the things that was, surprising to us was this Eastern European group. So interesting results. So again, we replicated these results for public health units, Toronto, Ottawa, Peel, and Hamilton. As a team, we were able to present some of these data to organizations working with Toronto Public Health. That happened in the fall of 2021. And later on, we found out Toronto Public Health actually held focus group discussions with agencies serving the Eastern European community. And those were done in 2021. They also requested a reanalysis of the data, and we found, when we did it again in winter 2022, that there was actually an increase in uptake in the Eastern European community. And that, this was pretty exciting for us to be able to, perform analyses, influence, some actions on the ground, and see some increased uptake. So that was really great to see, and a good collaboration with Toronto Public Health on that. So yeah, I just quickly wanted to put up context. If you're interested in any more information about the IRCC database, some folks up on the screen there, Sujitha Ratnasingham, Astrid Gutman, and Hong Liu. Hong, a great analyst at ICES, who can answer all your data questions as well. So after you see those results, you're probably wondering, why this is happening. And I think is really important, when we look at administrative data, it has no context. We don't know any of those reasons. And so to go to the literature or to talk to communities. And so, there's actually quite a lot of literature, exploring why we might see lower uptake among immigrants in terms of barriers, facilitators, and determinants. So I'd highlight 2 papers that were really great reviews. One, I think, published in 2021 by Tankwachi et al. In Current Opinion in Immunology, and that's on the left-hand screen there. Very great review. Also, a really lovely one in Lancet Infectious Diseases. Really great summary and that's in the middle there. I'll talk about that in great detail in the next few slides. I also want to highlight that so much literature out there talking about, understanding barriers and facilitators and determinants to vaccine uptake among, minoritized, marginalized communities, talks about the importance of community engagement in, tailoring strategies, in, identifying where the issues might be. And I think it's really important to highlight. So there's a really lovely article going through why it's important to do that by Burgess, and that's also in the Lancet. So just to touch upon that Lancet infectious disease article and what they found in their systematic review. So they had about 67 studies included in their review, and they looked at the determinants. So 25 of 26 studies identified geographic origin to be associated with vaccine uptake. So certain regions associated with lower uptake. Also highlight that duration of residence. So those who are most recently migrated into the country had lower uptake, as well as some groups of refugees or asylum seekers. So consistent with our results as well. So in terms of barriers and facilitators, there's a really great table in the Lancet Infectious Disease article, and this is what I pulled up on the screen. I apologize for the tiny font. So what I'll do is just kind of pair, a barrier and facilitator talk. Just mention them, and I highlight the ones that I think are really kind of resonate with what was happening with community-based discussions around barriers and facilitators. So here, a barrier was language literacy and communication, and a facilitator was tailoring information sources, and this is often what community organizations did to battle that particular barrier. There was also a lot of talk about distrust of the health system or authorities, a sense of alienation, disempowerment. This came up in those focus group discussions with the Eastern European community in Toronto. And again, to facilitate and improve on that, having culturally competent and migrant-sensitive healthcare and inclusive policies really balances that out. And I think it also helps improve trust in the provider and the system of the state. So also an important facilitator. A lot of literature also talks about migrants having worries about vaccine safety and side effects, which I thought I would highlight here as well. Education needed to address that. Another barrier was cultural, religious, and social barriers, so stigma, and that can be tackled with, again, tailored approaches around information and messaging. In terms of affordability and barriers, they talked about indirect costs, so the cost of traveling to vaccination appointments. And so to address that, address convenience, you have walking in clinics, having flexible appointments helped with that. And lastly, a barrier was having blanket approaches. So things that, thought we would apply to the whole population didn't really help. So having, again, tailored, culturally tailored and community-based interventions is really important. So I just, again, my last slide is to really emphasize the importance of community-based participatory approaches in understanding and addressing vaccine uptake, poor vaccine uptake among immigrants and refugee communities is really needed to sustain and increase coverage. And it should really be co-designed and meet the social, cultural, and linguistic needs. And this can be done through translation and tailoring of evidence-based information, provision of interpreters, and training of healthcare providers in migrant-friendly and vaccination guidelines. And interventions should really be implemented that address specific barriers and perceptions and context, and also that facilitate access to vaccines. And I just want to highlight, some examples I know that had occurred in Toronto. I'm sure there's some great examples happening across the province, but here's 4 on the screen. The Black Scientist Task Force did 20 town halls, reduced vaccine hesitancy among the groups that they spoke to. Punjabi Community Health Services did some great work in Brampton, a really hard-hit region in terms of COVID infections and mortality. They did some great work for reaching out to their community. Toronto's Chinatown around Kensington Market, and also the Latin American community in Toronto also did some great work. So I just highlight those examples, knowing that there's many more out there that I haven't heard about. So in summary, to end, so the main points I kind of want you to take away from the presentation are that the Canadian immigration process is highly selective. you can really consider it a structural determinant of health. It shapes people's health in terms of how they're selected based on some of those determinants, and also the immigration medical exam exclusions. And it's really critical that we start integrating a social determinants of health perspective into immigrant health research. And you can see some of how those social determinants of health played out in terms of those graphs that I displayed using Statistics Canada data. And we also reviewed, the linked data at ICES that helped demonstrate that there's a lot of variation in regions of birth in terms of vaccine uptake for immigrants and refugees in Ontario. There's a lot of really complex barriers to vaccine uptake. Some of them that we talked about, transnational social ties, distrust in the healthcare system and providers. And again, just to reiterate the point that community engagement and participation is really critical to overcome those really complex and nuanced barriers to vaccination experienced by immigrants. So with that, that's the end of my whirlwind presentation, and I'll just pass it back to Sarah for the Q&A.
Thank you so much, Susie, for that wonderful presentation. So we'll now move to the Q&A pod to address some of the questions. So there's quite a few questions. We'll try to get through as many as possible. So we'll start off with one that's maybe a little bit more on the data side. So are there any ideas about what future directions are in mind at ICES to more comprehensively capture race and ethnicity in administrative data? The individual in the chat has noted that in a recent presentation, there was a discussion about using proxies at the current time, including the IRCC data that you mentioned, as well as postal code data and surnames in certain situations. So wondering if you might be able, Susie, to provide any insight on how these things are moving forward.
So I guess the person who posed the question might already know this, but ICES just utilizes data that is collected from other people, so other organizations across the healthcare system, right? So IRCC was one of them. During the pandemic, I think this was only for COVID positive cases. Race ethnicity was collected. So we're limited by the data that ICES gets from others. Once the guidance document comes out around anti-racist approaches, it goes into a little bit more detail about how we really caution against using proxies, particularly country of birth, and even there's more restrictions on using the surname-based algorithm as well. What I want to stress, and I think what the Ontario Anti-Racism Directorate also stresses, is that it's important that people be able to self-identify their race, ethnicity, and proxies obviously just don't do that. So I think, one thing that we've been thinking about is, you want to talk about country of birth and kind of relate that to race, ethnicity, but you have to heavily caveat that and kind of know that, not everyone from Eastern Africa is going to be Black, for example. There's a really high proportion of people that are South Asian. So, once that guidance document comes out, there's a little bit more guidance in there about that. I hope that answers that question.
Thank you so much. I think it's so helpful to understand what is and is not possible in those administrative data. And maybe just tying along those lines, a bit of a point of clarification. When the ICES guidance document is finalized, do you know if it will be publicly available?
That is a good question. I actually don't know. I'll have to get back to you on that. I kind of assumed so, because I think part of it, one of the important aspects of it is getting regular Ontarians to participate we're trying to engage more with community members around use of that data. So I would think that the guidance document will be available for them to understand how ICES understands these data and why it's important to use them in a responsible manner. But I'll have to verify, and maybe that's something I can get back to you about.
That's great. Thanks. Yeah, something to follow up on maybe in a little bit.
Yeah.
So we have another question in the chat about the duration of residence, like length of time since immigration, and how you are using those data. So I'm wondering if if a standard definition is 10 years, or do some people use 5 years? And does it change if you are using child immigration status?
So there's no standard way to report duration of residence. often people describe newcomers as people who arrived in the recent, like in the past 10 years, and there's an intermediate period that's like 10 to 20, and long term is 20. I mean, ultimately, an analyst has control over how they categorize that. So there's no standard that I'm aware of. In terms of how people describe duration of residence for children, I mean, when you think about immigrant children, I think so much depends on when they arrive in Ontario, their actual age, arrive in Canada, because it's like, they're just developing so quickly. So I would think for like thinking about how a child adapts, and a proxy for that is probably more likely their age at landing and the age in which they're using services versus duration of residence. That would kind of be the way I would think about it. But for adults, typically duration of residence. We actually, it's an interesting point. We don't usually, that I'm aware of, think about duration of residence for children. But yeah, that was kind of how I make the distinction.
Great, thank you. And so maybe just time for one final question. So Susie, you've obviously been focused on examining immigration as a social determinant of health for a number of years. I'm wondering if you can share any reflections on if you think the pandemic has had any impact on drawing attention more to these social determinants and the need for these data.
Oh, great question. Thank you. Yeah, I think, the pandemic for sure has, we've heard it so many times that, the pandemic really shone a light on the social determinants of health, particularly race and ethnicity, mainly from, results coming out of the United States, but, that is easily translated to what was going on in Canada as well. Some of our earlier, we published a report in 2020 looking at infection and testing for immigrants and refugees, and we saw some big disparities, in the first 6 months. A lot of talk about essential work and how immigrants predominantly are employed in essential work, and I hope that some of the slides that I spoke to kind of allude to why immigrants are more in essential work than others, and just a great exposure. Something I haven't seen too much reported on is just the experiences of employment. Like the job itself might not be face to face, or you might actually be like someone who has a lot of interaction with somebody in your job. But if you are not able to access PPE, if there are so many other factors that can influence infection, and that's out of the person's control. So a lot of social determinants of health related impacts of the pandemic, and also talk about access to paid sick leave. So huge, right? Like people were not able to take time away from work, and that ultimately impacted infection in their coworkers as well. So yeah, lots of discussion around that, and I'm really is kind of a unfortunate thing that happened during the pandemic for like all the infections and all the hardship that people have experienced. But I think it's hopefully one thing that we can take home is that this happens across multiple health outcomes. It happens, it's happened for a long time, and the pandemic just really has shone a light on it for us. So yeah, we shouldn't forget about the social determinants of health. We shouldn't forget about thinking about immigrants, refugees, and their experiences in the country, and how we can improve on that for them in the future.
Thank you so much for that. So as we wrap up today's PHO's round session, I would really like to extend my thanks to Dr. Sujitha Wanagaratne for presenting. I would also like to thank everyone who joined us for today's session. Last, to access PHO rounds presentations and view confirmed upcoming presentations, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you so much for joining, everyone, and hope you have a wonderful day.